Welcome back to my channel. I'm Dr. William Lee. Today I want to begin with the story of a patient I'll call Thomas. Thomas is 71 years old, retired, and in relatively good health. One Thursday evening, he felt a slight dizziness as he got up from the dinner table. His vision blurred in one eye, like a veil covering it for a few seconds. Then it cleared again. His right hand felt weak for a moment when he held his coffee cup. A headache came on, unlike anything he had ever experienced before. Each one lasted less than 5 minutes. By the time he was about to call a doctor, they were gone. He decided to sleep. On Saturday morning, Thomas suffered a severe stroke. He survived, but never fully regained his ability to speak. His wife told me afterward, "I didn't know the things that happened the night before had names. I didn't know they were signaling something to us." That's the most common version of how a serious stroke happens. Not without warning signs, but preceded by specific, recognizable signals that are almost always overlooked. Today I want to make sure you understand what those signals are, what they mean, and exactly what to do when they appear. What Thomas experienced on that Thursday evening is called a transient ischemic attack, a TIA. Let me explain exactly what it is because the name obscures how serious it is. A TIA occurs when blood flow to a part of the brain is temporarily interrupted, most often by a small clot that partially blocks a vessel and then dissolves or moves before causing permanent damage. The symptoms are identical to a full stroke, but resolve within minutes, sometimes within seconds, and leave no permanent injury at that moment. This is why TIAs are dismissed. They feel like they were nothing. They were not nothing. Approximately 4 out of 10 people who experience a TIA will go on to have a full stroke. The risk of that stroke is highest in the immediate hours and days after the TIA. Between 10 and 15% of TIA patients have a major stroke within 48 hours. And critically, research shows that 43% of stroke patients had experienced TIA symptoms in the 7 days before their stroke. Symptoms that were noticed, felt, and ignored. The TIA is not a near miss. It is a direct warning that the vascular event that just occurred was incomplete and that the conditions producing it are still active. Every minute spent waiting to see if it happens again is a minute inside a window that is closing. Before the warning signs, I need to establish one number because without it, the urgency of everything that follows does not fully register. Every minute that a stroke goes untreated, the brain loses approximately 1.9 million neurons. Not cells that are stressed or impaired, cells that are dying and will not return. Over the course of an hour of untreated stroke, a person loses the equivalent of approximately 3.6 years of normal brain aging. The window for the most effective medical intervention, intravenous thrombolysis, which is the clot-dissolving medication, is 4.5 hours from the onset of symptoms. Mechanical thrombectomy, which is the physical removal of a clot, extends to approximately 24 hours in eligible patients. These windows are not guidelines. They are biological facts. A brain that has been deprived of blood for 6 hours has lost structures that no rehabilitation will fully restore. A brain treated within 90 minutes has a dramatically different outcome. This is why the phrase "time is brain" is not a slogan. It is a description of what is literally happening inside the skull while someone waits to see if the symptoms come back. The most effective tool for rapid stroke recognition is the BEFAST protocol. Let me walk through each element precisely because each one corresponds to a specific area of the brain and a specific type of vascular event. B stands for balance. Sudden loss of balance, dizziness, or difficulty walking without an obvious cause. A stumble when standing, a feeling that the floor has shifted, can indicate a stroke in the cerebellum or posterior circulation. This is one of the most frequently missed signs because people attribute it to tiredness or dehydration. E stands for eyes. Sudden blurred vision, double vision, or loss of vision in one eye, particularly the curtain sensation that Thomas described, which has the clinical name amaurosis fugax, indicates a blockage in the vessels supplying the eye or the visual cortex. F stands for face. Ask the person to smile. Facial drooping on one side, uneven smile, one corner of the mouth not lifting, indicates motor pathway disruption in the brain. A stands for arms. Ask the person to raise both arms and hold them at shoulder height. If one arm drifts downward involuntarily, that is a positive sign. S stands for speech. Ask the person to repeat a simple sentence. Slurred speech, inability to find words, or speech that is garbled and does not make sense indicates language area involvement. T stands for time. If any single one of these signs is present, even briefly, even if it is already resolved, call emergency services immediately. Do not drive yourself. Do not wait for the symptom to return. The time of symptom onset is the single most critical piece of information the treating physician will need. The BEFAST protocol is essential but incomplete. There are stroke presentations it does not capture, and they are more common in older adults and in women. The thunderclap headache defines hemorrhagic stroke, a ruptured vessel rather than a clot. It arrives at maximum intensity within seconds, the worst headache of the person's life, categorically different from a migraine or tension headache. Sudden numbness or weakness on one side of the body, one arm, one leg, one half of the face, without pain and without obvious cause, indicates motor pathway disruption. Sudden profound confusion, an abrupt inability to understand speech, or disorientation about place and time arriving without warning is a less recognized stroke symptom frequently attributed to fatigue in older adults. In women specifically, additional presentations include sudden generalized weakness, sudden nausea or vomiting without gastrointestinal cause, and sudden loss of consciousness. These are real, documented, and frequently delayed in reaching emergency care because they do not fit the classic picture. Recognizing warning signs is the first layer of protection. Understanding the conditions that make a stroke more likely is the second, because several remain directly addressable even after 60. Hypertension is the single largest modifiable risk factor, responsible for approximately half of all strokes globally. It damages arterial walls silently for years before the event. Elevated LDL cholesterol builds the atherosclerotic plaques that narrow cerebral vessels. Atrial fibrillation, the most common cardiac arrhythmia after 60, causes clots to form in the heart's upper chambers and travel directly to the brain, accounting for 1 in 5 strokes. Diabetes, smoking, physical inactivity, and obesity each contribute independently. 1 in 4 people over 80 has evidence of silent stroke on brain imaging, small areas of dead tissue that produced no symptoms but reflect the state of the cerebrovascular system. The vascular decisions made at 60 determine what the brain looks like at 80. Let me close with the protocol, because recognizing a stroke is only valuable if it is followed by the correct response. Step 1. Call emergency services immediately. Not after waiting 5 minutes to see if the symptom passes. Not after calling a family member to discuss it. The moment a BEFAST sign appears, or a thunderclap headache arrives, or any of the atypical symptoms we described occur, call emergency services. In most countries, that is 911 or 112 or the national emergency number. Step 2. Do not drive to the hospital yourself. Paramedics begin assessment and treatment en route and communicate with the receiving hospital so that the stroke team is prepared on arrival. Self-transport costs time that cannot be recovered. Step 3. Note the exact time the symptoms began. This is the single most clinically important piece of information. The decision about whether to use clot-dissolving medication depends entirely on how much time has elapsed. Step 4. Do not take aspirin unless specifically instructed by emergency services. Aspirin is appropriate for ischemic stroke, but will worsen hemorrhagic stroke, and you cannot distinguish between the two without imaging. Step 5. If the symptoms have already resolved, if you are now reading this and thinking about something that happened to you or someone you know last week that sounded like a TIA, go to an emergency department today. Not tomorrow. The window is not closed. It is closing. Thomas's wife told me she wished she had known one thing. Symptoms that disappear are not symptoms that were wrong. They are symptoms that were early. The stroke warning system is not broken when symptoms resolve. It is working exactly as designed, giving you a window. The question is whether you use it. If what we covered today has been useful, there are 3 things you can do right now. Press the like button, subscribe to the channel if you have not already, and share this video with someone you love, particularly if they have high blood pressure, atrial fibrillation, or a history of any of the symptoms we described today. They may not know what a TIA is. They may not know what the curtain across the eye means. They may not know that a headache that arrives at full intensity in seconds is not a normal headache. Sharing this video may be the most important thing you do today. Every week on this channel, we bring you evidence-based information about how the aging body works and what you can do to protect it. Until next week, take care of yourselves.